The human heart is a highly pressurized mechanical pump. For cardiac nurses, the primary job is identifying exactly how this hardware begins to fail. When that pump struggles, the PQRST assessment identifies the nature of the failure. We look for whether rest or nitroglycerin stops the pain, a sign of stable angina, or if the patient reports a crushing pressure accompanied by cold sweats and a feeling of impending doom. These symptoms change across different populations. Women, diabetics, and older adults often present with profound fatigue or what feels like simple heartburn. Recognizing these atypical signs is the only way to avoid the diagnostic delays that lead to irreversible muscle necrosis. This chart shows serum cardiac enzyme levels following a myocardial infarction. The sharp spike you see within 3 hours is troponin. It is the gold standard marker for detecting active myocardial damage, and it stays in the system for up to 14 days. If the issue is pump efficiency, we look to B-type natriuretic peptide. The graph morphs here to compare normal levels to severe failure. A BNP reading over 400 picograms per milliliter has a high predictive value for an acute heart failure exacerbation. Tracking these specific chemical markers alongside physical symptoms dictates the nursing pathway. These data points provide the lead time necessary to intervene before the muscle tissue dies. When cardiac output drops, the body triggers compensatory mechanisms like the RAS system to retain sodium and water. While this is meant to help, it creates a destructive cycle that overworks the already diseased heart until the pump physically breaks down. This split-screen diagram visualizes the resulting fluid backup. On the left side, blood retreats into the pulmonary veins, flooding the lungs and causing crackles. On the right, the pressure builds backward into the systemic venous circulation, leading to jugular vein distension and deep peripheral edema. As the diagram zooms in on the left ventricle, we can see the structural drivers of failure. In dilated cardiomyopathy, the walls become stretched and thin. In hypertrophic, the muscle grows abnormally thick and stiff, and in restrictive types, the tissue simply becomes rigid. Nurses manage this failure through strict volume control. The most reliable indicator of fluid balance is a daily weight check, where every single kilogram gained corresponds to 1 liter of retained fluid. This volume management extends to specialized procedures like continuous bladder irrigation, where the nurse must account for every milliliter of fluid moving through the system. To find the patient's true urine output during irrigation, you must subtract the input from the total volume collected. Total bag output minus total irrigant infused equals actual urine. By tracking fluid weight and calculating these exact outputs, the nurse reduces the physical volume load on a failing mechanical pump. The mechanical pump is driven by an electrical circuit that is highly sensitive to its environment. When the heart muscle experiences hypoxia or an imbalance of potassium, the wiring becomes irritable and begins to misfire. A normal sinus rhythm fires predictably between 60 and 100 beats per minute. If the rate drops below 60, the trace reveals sinus bradycardia. If it climbs above 100, it is sinus tachycardia. This animated trace shows atrial fibrillation. Notice the irregular QRS spacing and the quivering baseline where the P wave should be. Because the atria are quivering instead of contracting, blood pools and creates a severe risk for systemic clots. Pacing quickens slightly. If the rhythm shifts into these wide, rapid complexes that look like a mountain range, the heart has entered ventricular tachycardia. The ventricles are firing too fast to effectively pump blood. When the rhythm degrades into this chaotic, unrecognizable wavy line, the heart is in ventricular fibrillation. There is no coordinated contraction and no cardiac output. Rapidly identifying these electrical faults determines whether a nurse reaches for medication or the defibrillator paddles. If the patient has a pulse, we reset the circuit pharmacologically. We use atropine to speed up a bradycardic rhythm or push adenosine rapidly to momentarily stop and restart a heart trapped in SVT. But for ventricular fibrillation and pulseless VTAC, the heart requires an emergency asynchronous shock from a defibrillator. Defibrillation simultaneously depolarizes a critical mass of the myocardium. By causing a brief, total asystole, you allow the SA node to regain control and reset the heart's natural rhythm. Executing this safely requires the operator to shout, Clear, to ensure no one is touching the bed, and all oxygen must be turned off to prevent fire. Throughout the charging process, manual chest compressions must remain unbroken to maintain circulation. Restoring the electrical grid is a high-stakes, protocolized process. The electricity must be corrected instantly to give the mechanical pump a chance to restart. When standard mechanical and electrical therapies fail, the medical team turns to advanced invasive diagnostics and surgical fail-safes to stabilize the patient. For cardiac catheterization, the nurse manages the patient's NPO status and checks for iodine allergies. Following the procedure, the patient must keep the affected leg strictly flat for several hours to prevent severe bleeding at the arterial insertion site. Bacterial vegetations from infective endocarditis can physically destroy the valves and break off into the bloodstream. These cases often require surgical intervention to replace the damaged hardware and stop the formation of systemic emboli. In cases of end-stage cardiomyopathy, ventricular assist devices take over the heart's work. Because these pumps provide continuous flow, patients often lack a palpable pulse. These invasive diagnostics and mechanical assist devices act as crucial bridges, providing circulatory support when the native organ has reached its structural limits. The ultimate replacement is a heart transplant. Once the heart is received, survival depends entirely on strict adherence to a lifelong regimen of immunosuppressant medications. This new heart is denervated, meaning it is disconnected from the body's autonomic nervous system. It maintains a high resting heart rate and cannot rapidly adjust its output when the patient changes positions. Because the nerves are severed, the patient loses the ability to feel traditional chest pain. If they experience an MI or an episode of organ rejection, the classic warning sign of angina is completely absent. Nurses must instead monitor silent indicators of failure: sudden fluid gain, unexpected shortness of breath, profound fatigue, or the development of a new heart murmur. Clinical intervention depends on treating the scale, the monitor, and the patient's presentation as a unified system. When the mechanical pump and the electrical circuit are understood as a single interdependent architecture, the nurse can act before the system permanently stops.